Good evening and welcome everyone to this evening's HIS webinar. We are focusing this evening on waterborne infections, and we have a great lineup of speakers and expertise to guide us through the next hour or so. Before the webinar, we asked you to submit some questions. And these are to put to the panel. We have chosen 8 questions from among your questions, and these will be the first 40 minutes or so of the webinar. In the last 15 minutes of the webinar, there will be live questions, and we'd encourage you to submit these via Slido. I see someone has just put a point about that in the chat to everyone, so we will try and pick that up as the event continues. So once Slido is registering the event, you'll be able to interact and ask those live questions for the last portion of the webinar. So thanks to our panelists, I'm going to introduce all of us now. I'm Emer Brannigan. I'm an infectious diseases doctor, and I'm chairing this evening. And I'm going to start with introducing Daniel Pitcher, and he's going to tell you a little bit about himself. Daniel.
Thanks, Emer. I'm Daniel Pitcher. I act as an authorising engineer water for the NHS, working with many health trusts and health boards in Scotland. I've been providing independent consultancy support for the best part of 25 years. And certainly in the last few years, it's fair to say that things have become very interesting, and especially in the last 2 years, the amount of focus on design work, getting it right at the design stage, really has stepped up an awful lot. So as well as attending water safety groups, developing water safety plans, certainly the design element is something that's hotting up very much. Thanks, Emer.
Thank you, Daniel, and thanks for joining us this evening. Mike Weinbren, I'll ask you to introduce yourself, please.
Thank you, and good evening. I'm Michael Weinbren. I'm a medical microbiologist, work at Sherwood Forest NHS Trust and NHS Scotland Ashore. I've got an interest in water, and I chair the Hospital Healthcare Infection Society Working Party on water.
Thank you very much, Mike. And Teresa Inkster, could you introduce yourself, please?
Hi, I'm Teresa Inkster. I'm a consultant microbiologist based in Glasgow, and I also work with NHS Ashore, and I have an interest in waterborne infections.
Thank you very much. And finally, Jimmy Walker, who's had a busy day today.
Imer, thank you. You've noticed, yes, busy day at IPS, and in fact, my background is a research microbiologist, very much interested in contamination of water, very much interested in biofilms and the role that all that contamination in biofilms play in our water systems. And it was very clear today during the discussions after my presentation, which was the Christina Bradley lecture, which I was very proud to give, was that there's still a huge issue in terms of understanding of water systems from our healthcare professionals' perspective. But the biggest issue is that interaction at the water safety group level of your healthcare professionals and your estates departments, and talking the same language and understanding where each other need to be.
Thank you indeed. So welcome all, and we look forward to hearing from each of you over the next few minutes. Thanks, Jimmy. So first of all, we'll come to our first question, which is from Daniel. And here it comes now. And we're going to start with a little defining. So Daniel, if you could address this question, which is, what are the formal definitions for little use of an outlet? And following that, how many of our individual patient rooms in a hospital are likely to be little use outlets? Thanks, Daniel.
Okay, thanks, Emer. So I think the first thing we want to just clarify is the term little use. And 2 little words, little use, have actually generated a huge amount of reading and just cross-checking things my end. So having looked through current guidance, what I'd just like to do is just summarize what I found in current guidance documents using the term little use. So L8, there is no use of the term little use. They have used intermittently, and that's used twice. HSG 274 part 2, little use is mentioned 3 times, twice within supplementary control commentary and once within appendix 2.1 for risk assessment. And again, infrequently used is used 6 times, once within supplementary controls and 5 within the rest of the document. In HSG 274, there isn't a definition for little use or infrequently used. So then we go, well, we're healthcare. So what does HTMO4 part A, part B, part C, and SHTMO4 have to say? They don't use the term little use. They use terms such as infrequently used outlets, infrequently used equipment, infrequently used water outlets, infrequently used facilities, and in SHTMO4 it actually uses the term sporadically used outlets on several occasions. So making sure that I haven't missed anything here, I've cast the net a little bit wider, and I've looked at various British standards. BS 8680 on water safety plan, there's no mention of little used outlets there. 855468, the guide for flushing and disinfection, it talks about hygiene flushing. It doesn't mention little use outlets. And just to make sure it's not a historic thing, you know, people have these terms that float around for a long time. I looked at HSG 70, which was the pre-runner to L8, and that used the term intermittently used outlets. HTM 2040 uses the term showers being used regularly. And in HTM 2040 management policy from 1993, the appendix management checklist 3E, it uses the term identification of little used outlets and associated pipework. So just to be clear, the term little use outlet, one historic reference to it. In all the other references that are in all the guidance documents, it's only used 3 times in HSG 274 part 2. The most frequently used term is infrequently used outlet. So to answer this question, what is a formal definition of a little used outlet? I think it should actually be an infrequently used outlet. So what is the formal definition of a little used outlet, infrequently used outlet? Well, HSG 274 part 2 says a weekly or is indicated by risk assessment in terms of flushing a little used outlet or an infrequently used outlet. But it then goes on to say for high risk populations, healthcare care homes, more frequent flushing may be required as indicated by risk assessment. So in this instance, a non-healthcare, if an outlet is not being used at least weekly, then it would appear that it says it needs to be flushed at least weekly. A week is a long time in healthcare. So noting that HSG 274 part B says weekly is indicated by risk assessment, what risk assessment are we talking about? Well, I suppose what we're talking about is a clinical risk assessment to identify our patient cohorts of susceptibility. If we then jump straight to HTMO4 part C, and I'll start with the easiest bit first, it details infrequently used outlets to be flushed daily in augmented care areas. Excellent, so we've got a unit of measure already. Now, HTMO4 also goes on to say in healthcare facilities, remember part C looks at augmented care. Healthcare facilities, a risk assessment as agreed by the water safety group may indicate more frequent flushing than the weekly, and draw off should form part of the daily cleaning process. We've got another win there, daily cleaning, so daily use. So in my opinion, and I'm sure the rest of the panel might agree with me here, that little use or infrequently used outlets in healthcare setting is an outlet that's not being used at least daily. Daily use of an outlet is essential to minimize the period of no flow or stagnation, and daily use is regular use of the outlet to minimize the risk of microbial growth in a water system. Now, the second part of the question is, how many of our individual patient rooms in a hospital are likely to represent these? Now, this is how long is a piece of string? Not all hospitals are the same. Some are big, some are small, some are old, some are new, and all of the above. The key here is the clinical risk assessment to identify the patient susceptibility cohorts, then to determine what is in those patient rooms and what the use of those services are. So if you've got a bed-bound patient in an ensuite facility, it's a given that they're not going to be getting out of bed to use the shower, for example. So this needs flushing. And considering my answer to the previous element of the question, that would be daily. So a bit of a long-winded answer, looking at many different aspects, but to be clear, little use, that term isn't used in healthcare guidance, HTM or SHTM. Infrequently used is. But then what's infrequent? It would appear to be at least daily when we go for what the guidance has to say on flushing in augmented care areas, and that daily flushing is good for ensuring minimizing risk of microbial growth. How's that?
Thank you, Daniel. Comprehensive skim through the various supporting documents there, so that's great. Do our other panelists have comments that they'd like to add? Mike, do go ahead, please. Thank you.
It's more really from a practical point of view. I think what's quite useful, I find, is often when you're trying to remove an outlet, people often claim they're using it, and you often feel actually that's not the case. So if you want to be sneaky about this, what's quite good is to put a data logger behind the inspection panel, and that will record temperature changes. And then you've got irrefutable evidence if it supports you that this outlet isn't being used. And I think the other thing is, I think certain parts of the hospital, it's very difficult to, if you get somebody to do the flushing, to make sure they do it consistently. And I think we're all familiar with, looks like sheets which are filled in the night before they're due in. But I think with the new technology in certain areas of the hospital, having automatic flushing outlets, it can help with to ensure flushing takes place.
Thank you, Mike. Jimmy, did you want to add to that?
It sort of backs up what Mike was saying, some of what he's already said I was going to say, but basically it's using a building management system to understand what outlets are actually used infrequently, rather than just relying, as Mike was saying, on somebody with a bit of paper saying they've flushed it and that old signature being the same from day to day. It's just thinking about how can we use that remote monitoring, use that artificial intelligence that's now coming on stream to better understand the water systems to reduce that risk to vulnerable patients.
Thank you. Okay, shall we move on to our next question? That was a great start, I think. Bit of food for thought. And we move straight on to another very straightforward question. And this one is for Mike. Is it possible to permanently eliminate legionella and Pseudomonas from a water system without eliminating the water itself? Thank you.
Well, I hate to put it down on everything, but I suppose the answer is it isn't. We've got, in the UK, we've got good quality water coming from water treatment works, but unfortunately this water contains a rich microbial flora, and this includes a number of organisms which go under the name of opportunistic premise plumbing pathogens, and they share in common relatively resistance to chlorine, grow in amoebae, they don't need much in the way of nutrients, and they have the ability to form biofilm. And these include legionella, Pseudomonas, atypical mycobacteria, a whole list of pathogens which we're up against. So these will naturally get into our water systems. And I suppose the question is keeping the numbers down so they're unlikely to cause clinical disease. So if you look at our water systems, you can broadly divide it into two. There's the periphery of the system, there's the spurs. With a hot water system, we tend to have a recirculating loop. So it's the spurs coming off that as the periphery, that's the main body. With the cold water system, it's less distinct. But if we take the main pipes and then the spurs coming off that as the periphery. So in the hot system, if you have a well-designed system, and temperature control seems to be the main way we control legionella in the UK, and it's good for most other organisms. So we want temperatures above 55 on the hot and below 20 on the cold. If you have a well-designed hot water system, without any dead legs. You should be able to achieve this, so it's quite complex to actually, in the subordinate loops, to ensure the temperatures are going through the hot system, through all the loops, so to get even temperatures. But at the periphery of the system, we now, at the spurs, we put in materials which are high risk of biofilm formation. We put in thermostatic mixer valves, often in areas where you may not require them. And so this is an area which is difficult to control, and all the conditions are right for bacterial multiplication. So I think on the whole, one should be able to protect the main body of the water system. If you can't control that, then you can get quite explosive outbreaks. But getting the periphery of the system free of these organisms is extremely difficult. And so it's maintaining the water turnover. If you can get rid of thermostatic mixer valves and a risk assessment, this will reduce your risk. The HSE are actually very good in allowing you to do a scored risk assessment to remove these things, keeping the water turnover. So I think the periphery is a problem. You need to clean your TMVs regularly, keep the water turnover, change the shower hoses, and all of these things which eliminate the risk. With Pseudomonas, we have other ways it can enter the system. One of the areas we've seen, may actually occur with legionella, but probably people haven't looked for it, is people may wet test components during manufacture, and then you put them straight into your water system. So water safety groups should now be making sure, asking the manufacturers, are you wet testing them? If they are wet testing them, or what are they doing to mitigate the risk? Because this has bypassed all the protection systems. But equally, at the periphery of the system with Pseudomonas, there's a risk of retrograde contamination. So we often think about somebody not cleaning the sink properly, they'll clean the drain, and then introduce it into the outlet where you can get retrograde contamination. And I think we talk about water systems now, and it's very difficult to separate that out from the drainage systems. Because although, for example, organisms such as Pseudomonas, your water may be clear of Pseudomonas, there's well-documented spread from drainage systems to patients. So I think you can't stop these organisms getting in there. They will get in there. You can do a lot to try and minimize the risk.
Thank you, Mike. Are there comments from other panelists? Okay, well, here we go, Daniel. Just in time.
Yeah, I couldn't find the button quick enough, sorry. Thanks. I can't agree more with Mike on it's around us. It's about how you control your water system and getting that design right. Even with new designs, you know, the hot returns coming right to the outlet within, you know, let's say 500 or 300 mil, that's super duper, it's shortening that length. But that last little terminal bit, that outlet can be full of so many giblety bits that actually it allows so much to cling on if it's not designed right or it's not the right spec. And then all of that good work with getting that circulation working falls apart. Equally, the commissioning of these water systems, I've recently been involved in a project where the hot water system is designed to come right to within 300 mil, super duper. And when I went and checked the building, there were at least 90% of those return loops weren't circulating. But the commissioning agents were there going, it's fine, it's working. So like, no. You've got the hot water to the tap, but you're not sending it back. They're all the unknowns. That's it. That's where the problem is. So yeah, it's getting the design right, but then making sure that design works correctly. Can't agree more.
Thank you. Mike, do you want to come back and then maybe we'll move on to the next question?
Yeah, can I just echo what Daniel said? I think with new builds, it's just to say the commissioning phase is a very dangerous phase in a water system. If you have not actually, your commissioning phase needs to be decided right up at the design phase, not something which is done at the end. But so often nowadays, when we know so much about water systems, we're seeing water systems filled and nothing put in place, and the contamination of a brand new system occurs very early. And once it's contaminated, it's very difficult to eradicate that.
Thank you all, that's great. And just to, before we move on, just to let people know that Slido seems to be working again. So if you do want to think about some questions that you might ask in the live portion of our webinar, that would be great. So moving on to our next question, which is to do with the use of molecular technology. And this is for Jimmy, who's agreed to address this question. Do you believe that quantitative PCR is a useful tool for legionella water testing, particularly in a public health or hospital laboratory setting? And along with that, the value of qualitative PCR as a negative screen is clear, but how useful are genomic units to IPC professionals, hospital estates teams, and how to think about them together with the HSE guidelines? Thanks, Jimmy.
Well, thank you. I think it was Elise Maynard might have submitted this question. And I'm very, very pleased she did, because we get quite a lot of discussion around the use of PCR. Do I believe that it's a useful tool? Absolutely, I do. Having worked for many years with the standard plate culture and having to wait 10 to 14 days for a result to report that back to the hospital is far too long. However, the benefits are immense for PCR for water testing, but it's interesting that it's not really been taken up across the whole healthcare sector. And obviously there's other organisms as well, such as NTM, non-tuberculous mycobacteria, which grow so slow that could benefit immensely from the use of PCR. In outbreaks, absolutely terrific tool when you're trying to identify where that either that building is in the public domain, either or within a hospital where you're trying to match clinical isolates to a patient who succumbed to Legionnaire's disease within a hospital, and you're trying to identify that source. The sort of benefits, I think, immensely are that 24-hour turnaround. So the clinical team and the water safety team can then respond to those results. And then there was the second part of the question about negative screen. This has always been an area of debate, but it has such positive aspects to screening a water system where you can determine whether parts of the building you're working in are actually clear of Legionella. But what we have from that is the presence also of where there may be a positive, but there may be free DNA cells which may be dead. And so you're getting a positive result. But if those cells have been partly killed and releasing the DNA into the system, you could still have a positive PCR. And that's quite interesting, because what you'd be getting information there is that there has been that species or that isolate within the water system at some point, and someone may have, for example, used heat and or chlorine in order to kill off the Legionella that was in the system. Genomic units has always been an area of debate, and this is where we need to work with our different government bodies to try and bring forward the understanding of genomic units. Working with Sam Collins at PHE, Sam did some lovely graphs and correlations of genomic units to CFU, but we never really got there at the end of the day, because genomic units are different from colony forming units. It's a different process. And certainly with the standard plate count culture, we're losing a lot of the Legionella in the processing. And with the PCR, you're getting a higher result in terms of genomic units, and it's understanding what's going on there, because you're not losing those cells within the procedure of the process which you're analysing. There are other processes for genomic units, and what Sam tried to do was understand what the genomic result means for healthcare. And what we were looking at then was looking at, for example, 1,000 genomic units for a healthcare situation. And it's interesting that since the HSE have done a publication, I think it was January this year, where they looked at cooling towers, a very different environment, but that environment being a potential for an explosive outbreak of Legionella. They're looking at using 5,000 genomic units as an indicator of the quality of the water. But what we really need the HSE to do is to bring forward more statements, to bring forward more discussion in the guidance. And there'll be a discussion on that at the British Occupational Health Society meeting in November later this year. So that's about me on that. And I'd quite like to introduce it or invite the rest of the panel to discuss, because there's lots of debate around PCR and its effectiveness, but I'm certainly a great proponent of it, as I was at PHA.
Thanks, Jimmy. So that's the case for. Does anyone want to say something counter to that, or weigh in support?
They're shaking their heads.
They're shaking their heads. We've got unanimity here. Any other comments from the panelists, please? Okay. All on the same page. That sounds good. Okay. Thank you. Okay, so now we have a little bit of wishful thinking, and Teresa is going to take this question, thank you, which is, if you could run your own accredited water testing laboratory with finances for unlimited analysis at your disposal, what would you focus on and prioritise to improve a hospital's water safety? Thanks, Teresa.
So I think there are a number of areas where I would invest the money. The first one being development of lab methodology. So we've got well-established protocols for legionella, pseudomonas, E. coli, but we don't for the other opportunistic premise plumbing pathogens that can cause infections in vulnerable patients. So we're lucky during our Glasgow incident in 2018 that our lab were able to identify those, but we don't know if we had the optimal methodology to identify those organisms. For example, were we using the correct agar plates at the correct incubation temperature? So it would be useful to invest in standardised methodology for those more unusual pathogens. And similar to what Jimmy's already touched on, rapid diagnostics. So it would be very useful to have things like selective media, chromogenic agars, and PCR. And I think one particular area or organism that's challenging in a water system is your non-tuberculous mycobacteria, because they take a lot of time to grow. So a rapid diagnostic test for those would be on my wish list. The second area is around responsiveness of labs, and most accredited labs will have their standard water testing, and that's the bulk of the workload. But when you have an incident or an outbreak, you really need rapid detection, and you need to delineate the extent of the problem, and you may have to test other areas in your hospital to move patients to. So that needs to be resourced. So you need adequate staffing and skill set to do that. You need really a lab that can process samples 7 days a week, and you need to not be competing with the MALDI-TOF over the clinical isolate. So you need enough equipment to do that. So that's another area. And lastly, I think typing. So currently the guidance tells us that we should pick a single colony off a plate. And I think in doing so, we will miss lots of other strains and polyclonal outbreaks. So I think we need to increase our typing capacity, particularly in incidents, so that we can take at least 5 colony picks. And it would be useful to have typing more readily accessible during such incidents, access to emerging technologies such as whole genome sequencing during an incident in real time rather than after the event. So I think those are the 3 areas: the methodology, responsiveness, and typing.
That's great. Thank you, Teresa. Thank you very much. Sorry, you broke up there a bit at the end, so I'm just stepping in. No, that's great. Would anyone else like to go shopping with Teresa? Anything else you'd like to add? Mike.
Yeah, I think it's interesting what Teresa was saying about polyclonal outbreaks, because I think the temptation is at the moment, when we're dealing with patient to patient, we tend to think of a single clone going around. But in an environment where there may be a large number of different bits of biofilm in a system, I think we need to do this to find out how common polyclonal outbreaks are occurring, and whether actually we're missing a lot of transmission events from the environment, because we've got this very narrow view of how things spread.
Thank you. And Jimmy?
I was just thinking, Teresa, about the sort of the clinical aspects of molecular testing and how they can run suites of tests to look for what maybe the patient may be infected with. Do you think there may be room for that within this fantastic new laboratory you're setting up, so we can run suites of tests rather than relying on, for example, agar, and your situation you had in Scotland was using agar with total viable counts to look at the quality of the water as well? Sort of 2 aspects of that. It's your routine, and then your where are we with what's actually in there in terms of that polymicrobial?
So sorry, do you mean like a multiplex PCR?
Yes, sorry,
test?
yes.
Yeah. I mean, I think, yes, there would be a role for that. I suppose the only thing is if you had a specific organism that you were trying to detect during an outbreak, because there are an awful lot of waterborne pathogens there. So I suppose you could have a multiplex PCR for your usual suspects.
Great. It's an expensive shopping trip. I'm liking the ambition. That's great. Thank you, Teresa. Perhaps we'll move on then to our next question, and it's a slight change of tack, but this one is, I think, Jimmy, you're going to take this one, which is, has the response to the COVID-19 pandemic impacted on water safety? And if so, how? And what should we do differently regarding water safety in the next pandemic?
That's another great question. And being at IPS today has raised an awful lot of issues about how the pandemic impacted on an awful lot of people's lives. But certainly on our water systems, we know that they had to take many hospitals which were at full capacity, and then deal with the sort of situation where operations weren't urgent, and then repurpose parts of the hospital into specialist units for COVID, for example, changing theatres into areas where they had to house COVID patients. And these are not necessarily set up for hand hygiene, for hand wash basins. And it's putting in the repurposing of those water systems, but ensuring that those water systems are safe. But during the pandemic, was water management at the forefront of everybody's mind? I doubt it very much. I think there were much higher priorities. In China, there were quite a few studies carried out where they looked at the hospital occupation before and after the highest parts of the pandemic, and they were able to demonstrate that the microbiological quality of the water deteriorated to the extent that they had more coliforms, legionella, E. coli, and Pseudomonas aeruginosa in the water. So certainly in a number of hospitals, there was an impact on the quality of the water, and that would have had an impact in terms of patients. We know there were a number of patients who had co-infections with COVID and also with legionella. Daniel might be able to talk on some of these aspects as well, where there was a number of companies, of the water management companies, weren't even allowed to have access to take samples at the height of the pandemic. And this was all about protection of workers and responsibility and due diligence and care. And that would have an impact, because if you're not getting the samples taken, you're not getting the results. It's some of the things that Mike was talking about earlier on in terms of looking at the use of water and the cold supply being kept cold, the 12 hours of water in terms of a cistern, and then the hot water to try and keep it moving. And then through a number of organizations where a number of microbiologists we were able to work with internationally, and through the European study group for the Legionella, we were able to write advice for hospitals. And that meant we could write advice for current hospitals. We were trying to shut down parts of it. Nightingale refurbishments, we were opening up for new patients, but also for dentists and other healthcare settings, because it was really important that they had the risk assessments in place to enable them to understand what to do when they were actually reopening up hospitals. And I think with that, working together with different collaborators and different microbiologists, we're definitely in a better place now for the next pandemic. And I'd really like to thank all of the microbiologists who were involved in that and how much work it was, including all the professionals and healthcare professionals who put an awful lot of work in with us to try and ensure that the water systems were managed, but there were other priorities, and I think most people did the best that they could at the time. Thank you.
Thanks, Jimmy, for those comments, and well done for keeping going. Daniel, would you like to follow up there?
Thanks. Yeah, Jimmy raised the point about accessing these healthcare facilities for taking samples and during the pandemic. My experience has been either side of being able to being allowed access. We've heard stories of some organizations saying nobody can come in So the samples, the flushing, the monitoring wasn't being done. But equally, some organizations, some healthcare organizations have said, well, actually, we've got a hospital that's really empty. Avoid the hot areas, the red areas. You can come in and do the sampling, the flushing. So that's an interesting understanding within the different healthcare organizations on how they've actually done that. But equally, the estates teams and the contractors, their own ability to do work during the pandemic with people self-isolating and the impact of service delivery, either in-house or externally. Some clients, you know, have said, gosh, we've got half the estates team sick because they're self-isolating. We can't physically get out and flush all of the outlets in 75% of the hospital that's now empty. And then they're calling on contractors who are saying, we've got people who are self-isolating, we haven't got the resources available. So it's a really tricky situation. And yeah, sure, learning for the next time round. And I think one of the learning there is a hospital, although it was, you know, getting people out and focusing on those repurposed areas, most of the hospitals still remained empty. That then needed looking after, and people could come in and look after it whilst taking appropriate precautions. But some of the individuals locking down, going, no, you can't come in, it's a hospital. Yeah, some rethinking there.
Thank you. And Jimmy, did you want to come back on that?
Only to come in and think about some of the aspects of water management system we were talking about earlier, talking about automatic flushing, remote monitoring, and how these aspects could help us from a remote distance to manage that water flow and the safety and quality of that water without having to get on site. It doesn't tell you the microbiology result, but it tells you whether your system is being maintained appropriately or not.
Thank you. Thanks for those thoughts and reflections. I think there's probably a lot that we could discuss further on that, but just conscious of time and the three further great questions we have in this part of the webinar. Let's move on. And Teresa, I think you're going to talk to us a little bit about this question, which is, what, if any, formal communication do we need to start getting out to our elderly, immunocompromised and vulnerable patients about the potential risks in our non-sterile healthcare water? Thank you, Teresa.
Thanks. So certainly I think our immunocompromised and vulnerable patients should be given communication. So in my own hospital, that's the hemato-oncology bone marrow transplant patients who are obviously profoundly immunosuppressed and will often have Hickman lines, which are a risk factor for gram-negative bacteremia. So the advice that we would give these patients is to avoid drinking sterile water and to only use sterile water for toothbrushing until their neutrophil count had recovered. In addition to that, things like flushing the shower for several minutes before they go in and covering that line site with a waterproof dressing. So I think that's very important that they understand the risks from water. They may also visit other areas within the hospital and assume that the water there is safe to drink or use. So yeah, I think beyond that, it's about trying to get a balance, and it maybe depends on your own local situation and what the risks are, because patient hygiene is very important. So we don't want to cause unnecessary alarm to certain patient groups. I think there is one area where we do need to communicate to all staff and patients, and that is around sink hygiene. And I think there are two aspects to that. The first is around decanting fluids and objects down drains, because that's a source of nutrition for biofilms. You know, dropping objects down drains can lead to obstruction and stagnation. So I think we need to educate them on the risks of that, and also around storing toiletries and cosmetics on the top of hand wash basins. That makes them difficult to clean. These products are also a source of nutrition and they can become contaminated themselves. So I think for infection control teams, there's bespoke advice for your high-risk vulnerable group, but also general advice to all your patients and staff around the aspects of sink hygiene.
Thank you. That's great. Does anyone want to add to that? Jimmy?
Yeah, Teresa, I was very fortunate, as I mentioned earlier, to be speaking at IPS this morning. And I was about halfway through my talk when I realized that a number of images which I'd shared from some colleagues, the amount of items on the back of the hand wash basin. Why do we have this, what is basically a shelf on the back of the hand wash basin? I think there are some areas we need to think about design of hand wash basins themselves. And I know Mike's quite often gone on about the hand wash station design and where things are above the hand wash station, but if we can get away from having this little shelf at the back. The other person who spoke today this afternoon was Joost Hopman, and his work on, I think someone's going to be talking about the Waterless in a couple of minutes. Really interesting, really interesting. So I'm looking forward to how the next questions are going to be debated.
Thank you both. And Daniel, do you want to add in?
Just a little bit there. When we think about formal communication, you know, there is the water safety group, and one of the remit elements of the water safety group is communication to the organisation. So the observations and learning from around the estate, what's being seen, and sharing across to other departments, and getting the feedback and that information out. It must come out from that water safety group. That water safety group's got all the key players. That's where the brains and the knowledge is. That's where it's got to go out from.
Thank you. And Daniel, we might stay with you then and just move on to the next question, if that's okay, which is to do with getting a little bit of control, perhaps. And this is about point of use filters, which are described as a temporary control measure. But what happens when a hospital has to use these as a long-term or indeed a permanent measure?
Sure.
Daniel.
So thanks. Well, HTMO4 part B provides a really nice answer to this. So I'm just going to rattle through this and then do some explanation. So chapter 7, paragraph 45, so 745, point of use water filter. Point of use filtration should be considered and agreed by the water safety group only as an interim safeguard where control measures have been ineffective, or prior to and during engineering remedial works, during periods of plumbing refurbishment and maintenance works, and where additional protection is required to vulnerable patients. Continuous long-term use of filters is not recommended, except where there's no effective alternative. The water safety group should review their continued use and ensure an action plan is created and enacted to make certain that they are changed at intervals specified by the manufacturer. So for clarity, point of use filters are an interim safeguard where control measures are ineffective or additional protection is required. This continuous long-term use, not recommended, but where there's no effective alternatives, yes. The installation and use of point of use filters is one thing that needs to be agreed. They're not just to be thrown out there around the facility. You know, they're there for a reason. They only have a limited amount of life. So to put them on and forget about them is going to cause some problems. So the installation of point of use filters being agreed by the water safety group. So there needs to be this well-defined water safety plan that outlines what remedial actions are required in response to positive water sample results. So HTMO4 part B and SHGM provides details for legionella, for example, on positive water sample results. So in figure 4 within HTMO4, it's got the action levels for legionella. And here we go, 1,000 to 10,000 CFUs. It says, if a shower spray outlet cannot be taken out of use, consider installing the point of use microbiological filter. Greater than 10,000 CFU, if the outlet cannot be taken out of use, install a point of use microbiological filter. So the installation of these filters is an informed decision. Now, where water sample results are returning these positives, there will be reasons for the bugs growing in the water. There are going to be multiple favourable conditions that will exist that need to be identified and resolved. Some of these resolutions might be quick engineering fixes. So the replacement of an old TMV and tap with a new TMT with an integral blender, relatively quick solution, where some engineering fixes may require greater input, closing of an area, decanting of an area, repiping of a water system. So the use or how long a water filter is there for depends on how big the problem is and how many things that are wrong. And until that water system is back in control and the water sample results are within tolerable thresholds, the use of a point of use filter needs to be reviewed with this data. And when there's confidence in that data, then the consideration for removing those point of use filters comes about. So point of use, an interim safeguard when you're out of control, use that point of use filter. But it should only be an informed decision, and find out what the problems are and get them fixed.
Thank you. Any additional comments? Jimmy, you're on a roll.
No, just it's raising the issues. Point of use filters have a role to play, but from experience, there's a number of situations where it's problematic to use one, and might want to touch on this as well, but where you've got that lack of activity space within a hand wash basin. You've added a filter, you don't have enough space to wash your hands. Potentially, it's not just a lack of space for washing the hands, you're potentially setting up a contamination of the filter from the hand wash basin, or indeed breaking that air gap that you've got there, protect backflow. So there's a lot of usage issues you have to look at, as well as thinking about the microbial control of the water which would flow through it, which is what you're trying to control. And I think, as we're all aware now, that retrograde contamination from the drain isn't controlled by the water filter, and that's where the whole healthcare responsibility comes in maintaining and having that planned preventative maintenance program with those components around that hand wash station.
Thank you very much, Jimmy. Okay, conscious that we have a queue of questions. We might need another hour, guys, but anyway, not this evening. It's okay. But conscious of that, we'll go to our last really straightforward question I'm looking to Mike to address this question, which is, do you think waterless ITUs are the way forward? And if so, what do you envision to be the major challenges and solutions in implementing them? Thanks, Mike.
Yes, I think there's a strong argument that these are the way forward for the following reasons. I think the first area in a hospital, as far as I'm aware, to go waterless was a non-clinical area, and this was the sterile drug preparation area in hospitals. And this followed an outbreak in Manchester in 1995, where there were pediatric deaths linked to contaminated TPN from a nearby sink where splashing went into it. So from 1996 onwards, the Farwell report came out, and their view is water is so dangerous, you take it out of the sterile preparation area, you wash your hands, you can use alcohol gel in there, you don't have water. Then it was a bit later, and Jimmy's already mentioned it, I think Joost Hopman in Holland was the first person to develop the concept of a waterless ITU, and we've been to visit it. It is very interesting. And this was introduced because they had an intractable problem with a highly resistant organism emanating from drains. But the interesting thing was, following going waterless, they found there was an overall reduction in transmission of all gram-negative organisms. So what they were suggesting was that we are missing, our surveillance is not good at picking up waterborne transmission events. And I think there is other evidence to support this. In fact, Jimmy was one of the authors in a paper looking at 4 hospitals in the UK. They looked at 4 augmented care areas in each of these hospitals. None of them were aware that they had a problem with endemic transmission, but using whole genome sequencing, and they weren't even looking at the drains, just at the water, they showed that there was ongoing transmission of Pseudomonas to patients, which was unrecognized. There was another study in France where they looked at ITUs. It was a national study, multi-drug resistant organisms. And what they found was that if you had a sink which was contaminated with a multi-drug resistant organism, more than 50%, there was splashing, it was within 2 meters of a patient, and you weren't using bleach down the drain, you were getting transmission events. But I think the worrying thing is people are not looking. You know, you should be able to walk into these ITUs and see, well, actually, those sinks are not in the right place. And I think a lot of the problem comes from the fact we've never really taught people how to interact properly with water services. So one study found that in an ITU, they put a video camera above the sink. They couldn't see the people, but they could see what was happening. Only 1 in 25 visits That's 24 out of 25, or 96% of visits to the hand wash station were for the wrong reason. And I think the other thing to say about hand wash stations, as Jimmy said, I don't think we've probably got an ideal design. We know sinks with a rear drain are less risk of dispersal of organisms, but they also run a problem that their drainage becomes impaired because they don't have a sieve. And I think another area with sinks, which is slightly less recognized, is the use of elbow-operated outlets. Studies have found that 90% of people will turn on an elbow-operated outlet with their hands, wash their hands, and 70% will then turn the elbow-operated outlet with their clean hands. So this may be another area for transmission of not just water and drain organisms, but for a variety of organisms, because these are now become highly touched objects and are a risk. So I think there is an argument. There has been the odd paper which says people have found highly CPEs down their drains. There's been no transmission, but there are so many variables. Nobody's giving us a full information. So I would say that's the way forward. And I think, what CPEs I think are showing us, or other multi-drug resistant organisms, is we don't believe they possess any special characteristics which allow them to transmit. But we're much more aware of them. We see them. We don't see the sensitive organisms. In fact, we've got no baseline in adults for what is an acceptable level of Pseudomonas aeruginosa endogenous carriage on an ITU. And this has caused problems in, I think, one Swiss burn unit. It took them 3 years to find out they were getting transmission because they didn't realize, they couldn't distinguish whether it was endogenous carriage or acquisition. So I would say yes. And especially now when we're trying to preserve antibiotics, why wait for a highly resistant organism to come around to show you the deficiencies in the system? So we need to change things. In terms of moving forward, what the difficulties, I think you need to win over clinical teams. I think the trick is, if you can do it, is to make them think it's their own idea. The great advantage of that is if anything goes wrong, they can only blame themselves. I think the people worry about Clostridium difficile, but I think we've got a balance. There's probably the number of times you see Clostridium difficile on most ITUs augmented, I should think, is relatively small. We're seeing a lot of waterborne transmission events. You can bring in standalone mobile sinks. I think more research needs to be done. Could wipes be just as effective as using water for these resistant organisms? And I think what it also brings to the fore is, when you no longer have sinks there, you start finding out what people have been doing in terms of disposal. They can no longer pour it down the sink in the room. So I think, we need ways of getting rid of fluids in the room, and it may be things like these absorbent granules for small amounts of fluid in a box are a ways to doing this. But I think, yes, I think there's a lot of potential for this in the future. And the other thing, just to say, that a paper's come out which shows that using non-water based products for cleaning patients seems to be just as good as using water. Thank you.
Thanks, Mike. I won't take further questions from our panel, but let's see if we can fit in a few of our live audience questions. I believe there's a long queue of them, and we should try to choose. So there's a few at the top here that have been chosen. And the first one is, should monitoring non-tuberculous mycobacteria in water be mandatory in certain healthcare settings, and perhaps which of those settings? This is open to any of you, so do please go ahead. Mike.
Well, I think we're learning more about atypical mycobacteria and causing issues. I think certainly there have been outbreaks in America. I think there's a hospital over here currently with Mycobacterium abscessus. So I think in very high risk patient groups, we need to do something about atypical mycobacteria. Whether it's monitoring, or whether we should be putting in preventative measures, perhaps before we talk about not using point of use filters. But I think it's an issue we have to address these high risk patients. Monitoring may be part of it, or we decide to use preventative measures as we learn more about this organism. I think also atypical mycobacteria You know, we worry about healthcare, but there's an element of people in the population. I think Joseph Falkenham has done work in the States that shows that people who are getting chronic lung disease with some of these atypical mycobacteria, you can go back into their own homes and show it's linked to the water system, especially showers. Showers are becoming more common. So it may be a bigger problem that we have to address, not just within in the healthcare setting.
Thanks. A comment from Jimmy, and then we'll move on to another question.
Thank you, Amy. I was just thinking in the context of Teresa super lab. One of the big issues with non-mycobacteria tuberculosis is the fact that we don't really understand enough of the problem. Because if you take the Mycobacterium chimera scenario, we had to wait for 1.5 to 3 years before the infections manifested in those patients. So I suspect there's a huge catalogue of infections that potentially could be occurring that we don't even know about, because patients have left the hospital a long time before the infections come back. So I think there's a lot of work still to be done yet, but whether it's mandatory or not, I'm not sure yet. We're still struggling with legionella, I think, in some contexts.
Thanks, Jimmy. I'm just going to, just in fairness to our audience, I'm going to try and get through a couple of questions, and I'll maybe get one of you to comment on each one if that's okay. So our next one is someone describing that they had legionella detected in patient bay sink outlets, discovered on extended testing on the back of a suspected case. However, the regular sentinel testing in the preceding months always showed 0 CFUs of legionella, falsely reassured. And so this is a question about what would you recommend to close this gap? Jimmy.
I would like to know what the laboratory were doing in terms of testing in the first place. We have a lot of scenarios within the experience of Public Health England where we would take a litre of water and someone else would take a litre of water and we would find a positive and this other lab wouldn't, be partly sometimes because they'd only be filtering 500, 250 mils because it's quicker. And that's not to denigrate the laboratory, it's a commercial entity and they need to get through those samples. And it's where, again, Teresa's lab comes in. We can make this much more automated and work towards having a more effectively managed laboratory system to get results back to the hospitals, which are more, enable them to do more clinical care.
Thanks, Jimmy. Could we see the next question, please? Estates and facilities are under-resourced. We know that for sure. And extended water testing is not always possible. What is the minimum recommended frequency for water testing for Legionella pseudomonas in clinical areas? Sorry, I can't see my panelists and their hands, so does someone want to just jump in?
Thanks, Emma. I'll jump in on that one.
Thanks, Daniel.
That's okay. So with the Pseudomonas, the minimum frequency for testing HTMO4 details every 6 months. If your test comes back negative, don't worry about it for 6 months. If it comes back positive, then follow it up within 3 days, 2 weeks, 4 weeks of with retesting. And with Legionella, it's a bit more of a broader brush there. If we're thinking healthcare, the guidance says, you know, consider Legionella testing where you've got susceptible individuals. So that clinical risk assessment where you've got these susceptible individuals. But the Legionella testing to go with that really needs to be supported by the routine monitoring data. The routine monitoring data proving the water system or the strategy of control temperature. Let's take temperature as the traditional strategy. If that's coming back and it's proving that the system is great temperatures. Maybe you look to do Legionella sampling at a set frequency. And for some of our clients, we've done weekly testing for 3 weeks and it's come back negative. So we moved to monthly testing, 3 months negative. We then rest at quarterly as an assistance monitoring and assurance monitoring to that routine testing. But where you have got a problem, then the guidance does say, you know, perhaps look at doing weekly testing until you're back in control. And that control is you've got evidence that your control strategy temperature is working, and that you've got the positive, not positive, you've got legionella tests that help prove that the control is there where you're getting negative results.
Thanks, Daniel. I think we have, Mike, do you want to come in quickly, and then we've got one last question?
Or maybe go to the last question.
Okay, great. Thank you. Our last question, again, this is just to be fair to our audience who've submitted loads. And this is to Teresa. Teresa, would you choose sterile water over filtered water? There we go.
It's a difficult question. Yes, I think I would use sterile water over filter water. Sterile water is recommended by the WHO for immunosuppressed patients, either sterile water or cooled boiled water. When people's neutrophil counts have recovered and they are due to go home, they are often advised to use filtered water at home, provided they change the filter frequently as per manufacturer's instructions. But I think sterile water is probably your safest option if you can provide that. We had some concerns during our incident in Glasgow about filter failures or surface contamination of the filter. So I suppose there is a small possibility that filtered water could still become contaminated. I don't know if anyone else wants to say otherwise.
Yeah, any final comments? Okay, thank you. Thank you, everybody. I think that's all the time we have for questions. I'm afraid there are lots more questions, and certainly plenty for perhaps another session, another day. So in closing, I'd just like to thank our panelists. We've seen, I think, this evening the breadth and depth of their expertise, and perhaps some of the scars of their experience of having to look into some difficult situations for our patients. And our colleagues having to respond to these. So thanks, everybody, and thank you to all our participants. Thank you for all your questions. And thank you to our support from Gamma Healthcare, who supported this with an educational support grant. Certificates of attendance will be available and sent out after the event. And the recording, as usual, and transcript will be available after the event. And hopefully you all already know that our previous webinars are available on the Healthcare Infection Society website. And I suppose an early flag for your diaries that forthcoming webinars have been scheduled for the 3rd of November and the 24th of November. So do look out for details of the topics and get your thinking caps on for some great questions, some more great questions. And thank you for submitting questions in advance this evening. Thank you very much.